Welcome to Tech Jam. My name is Kathy Resmer. I am the deputy publisher of 7 Days newspaper. This week we have our tech issue. You can pick it up on your way out from Hula from today. And we are really excited to bring you this event again. We've been organizing the Tech Jam since 2008. A lot of different kinds of tech have come up since then, many iPhones ago. We couldn't do this without help from our presenting sponsors. I want to thank Marvell Technology. They're out there in their booth. And Hula, our amazing hosts at Hula. This facility seems built for Tech Jam, quite honestly, and we are very fortunate to be here today. And I want to introduce, to say a few words, the CEO of Hula, Lucia Campriello.
Thank you so much. Happy Tech Jam. Today, that is a little bit slick, just FYI. I think it might be the soles of my shoes. Happy Tech Jam. Welcome to Hula. It is so good to see you all here today. It was so good to see all of the first robotics students in this room earlier today. It is so good to see all of the employers out there who are hiring actively. I could not agree with you more, Kathy. When I think about Hula's mission, which is to elevate Vermont entrepreneurs and create connections that drive growth and spark community, I think of events and convenings like Tech Jam. This feels like it's Hula's mission in action. So can't thank you enough for this incredible partnership that we so enjoy with 7 Days, for bringing programming just like this to our campus. We were built for this work. As Kathy said, my name is Lucia Campriello. I am the CEO here at Hula. I told you a little bit about our mission. And I just want to linger for a quick moment on some of the work that we do every day to connect talent seekers with talent seekers with the companies that are seeking their talent. That happens every day. I spend a lot of my time doing work like that in my day-to-day, as do so many Hula members, informally in person, visiting with members inside of our community, members from people who live in Vermont across the state, folks who are moving to Vermont, which is exciting. We want more people to move to Vermont, connecting those folks to employers. We have ways for folks to do that work in our digital community, which includes an incredibly robust Slack channel dedicated to employment seeking. There are over 1,100 individuals actively in that Slack channel, posting jobs daily, connecting with members inside their own companies, looking for specific talent, specific needs within their companies here on campus, also posting jobs from around the state. So if you know a Hula member and you have a job opening in your company, or if you're someone who's looking for a job, get your resume to a Hula member, because we have access to a whole bunch of other people who are equally enthusiastic to connect you with jobs and with employers. We also do that with much younger people as well, and thinking a lot about student talent, which is a passion of mine. For some of you who know me, you know I am an advocate of education. I get to do that work as a volunteer advocate with Vermont's Child Care Campaign, thinking about the importance of education beginning at birth. I get to do that work as a volunteer school commissioner within Burlington School District in our K-12 system, and I get to do that work as a trustee of Champlain College. There is nothing more important than connecting student talent to talent seekers and to retaining student talent once those students are here, whether they are from Vermont, keeping them here, or coming from outside of the state. A program very specifically that I'm so excited that we have connected with is the King Street Center's Academic and Career Exploration Program. This program connects high school students, the majority of whom live less than a mile up the street on Pine Street. Majority of whom are at school at Burlington High School, connects them to prospective employment opportunities and higher ed opportunities. In fact, I saw my good friend Jamal Aiden here earlier today, who I met 2 years ago as the assistant director of that program. He was newly enrolled at UVM's electrical engineering major, and when I asked him what he thought he might do upon graduation, he said, "I don't know, but I'm sure I'll have to move to Boston or New York." I took that as a call to action and immediately connected him with a bunch of employers, many of whom are out here today. When I saw him today, he graduates in May of 2027. I said, what are you thinking of doing? Who have you connected with so far? He said, I've connected with a lot of prospective employers. I don't know exactly what I'm going to be doing, but I know that it's going to be inside of the state of Vermont. So all it takes is one person making that connection, and you all are those people who can make those connections. So I call upon you to do that. We also have an awesome program in partnership with Champlain College. We've got a team of staff who sit right on campus and connect Champlain College students with companies based out of here at Hula. Over 100 companies work from Hula annually. Those staff people have their fingers on the pulse of what founders are looking for, what challenges they're looking to solve, and connect those students to those founders. It's a really incredible program that we're fortunate to enjoy. The last thing I'll say is that Hula has also begun to bring interns into our very small staff team. This summer we enjoyed awesome interns from UVM, from Champlain College, from Middlebury. We anticipate continuing that internship program within our small organization, but more importantly, embracing the collective interns who work across campus, which totaled 30 this past summer. Those 30 students came from, 10 different schools in 7 different states. And to the extent that we can not just connect them with the employers who are located here on campus, but connect them more broadly with employers throughout Vermont, we're really excited to build out that program. And again, use this place as a convening for employers and students to make those connections. So clearly, when I am unscripted, I can go on because my enthusiasm is probably on display right now, but you're not here to hear from me. You're here to hear from this incredible panel, which is actually on a slightly different subject. So I will pass the mic back over. Again, huge thank you to 7 Days. We love Tech Jam. Thank you all for being here. Thank you to the employers for being here. Thank you to the employers for hiring, and have so much fun.
Thanks, Susha. Wow. Thank you. And so 7 Days actually also makes those connections, and that's one of the reasons we're so thrilled to partner with Hula and to bring this event here to you today with all of these employers and partners. And it's so exciting to hear when people talk about they had, people behind the booths are talking about their first Tech Jam when they got hired. So that's really cool to make those connections. I also want to thank our other sponsors for this event. We couldn't put it on without them. Vermont Information Processing, VIP, Norwich University, Vermont Technology Council, Northfield Savings Bank, Global Foundries, Bechtel, Data Innovations, and the University of Vermont's Office of the Vice President of Research. Thank you to them. Someone who is not a sponsor or an organizer has put these pamphlets on some of the back seats. You might have seen them. They're green flyers that say, AI, a wolf in sheep's clothing. That is not from us, but someone has very strong feelings about this, as many people do. So I'm so excited to hear from this panel today. And I want to welcome to the stage my dear colleague, Ken Picard, 7 Day staff writer.
Thank you, Kathy. And thank you. In the history of medicine, only a few technologies have truly redefined how we think about health, sickness, and care. From the invention of the X-ray to the discovery of penicillin. Today, we stand at the threshold of the next great transformation, the integration of artificial intelligence into the entire US healthcare ecosystem. AI is not just changing the tools that doctors use, it is fundamentally reshaping the patient journey, the hospital workflow, and the future of biomedical research. The sheer speed of this transformation is stunning. We are already seeing AI move beyond theory and into the clinic. In medical imaging, AI algorithms can now analyze complex CT scans to detect early-stage cancers with higher accuracy than the human eye alone, reducing diagnostic errors and saving precious time and lives. In the pharmaceutical world, AI is accelerating drug discovery, sifting through millions of molecular compounds in days rather than years to identify therapeutic targets. And in our often overburdened hospital system, generative AI acts as a virtual scribe, automatically documenting doctor-patient conversations directly into the electronic health records. A huge step forward towards reducing clinician burnout and bringing the focus back to the patient. But this incredible promise is shadowed by equally serious public concerns that we, as a society, must address head on. We have crucial questions about equity and bias. If an AI diagnostic model is trained predominantly on data from one demographic, will it systematically misdiagnose or underdiagnose individuals from marginalized communities? We must grapple with the fundamental issues of data privacy and security, ensuring that the vast, sensitive amounts of patient data required to train these powerful models are protected, transparently governed, and secure under strict regulations like HIPAA. And perhaps most crucially, we must safeguard the human touch in medicine. The human touch, that's an interesting choice of words for the AI that I asked to write my introduction here. From a one-sentence prompt. But I know that you're not all here to find out what artificial intelligence has to say about AI in healthcare. That's not why we've brought together this distinguished panel who could offer us valuable human insights into how AI is redefining healthcare in Vermont. Because whether we like it or not, AI is here and it's not going away. So I'd like to introduce our three panelists. Dr. Justin Stinnett-Donnelly is Chief Health Information Officer for UVM Health, the state's largest healthcare provider. He's also an adult hospitalist who is board certified in clinical informatics and internal medicine. Justin describes himself as a passionate advocate for leveraging technology to enhance patient care. And as a hands-on physician and IT leader, he brings a unique perspective to optimizing healthcare delivery, always placing people and experience above technology. Dr. Stinnett-Donnelly also co-chairs the UVM Health AI Council. Justin, thank you so much for joining us. Ethan Bechtel describes himself as an optimist and an entrepreneur. He is co-founder and CEO of OhMD, a company that is putting an end to hold time on patient calls. He's also headquartered here in this building. A graduate of the University of Vermont School of Business, he helped bring healthcare into the digital era through early works on electronic health records. At OhMD, Ethan leads a team that is building AI-powered communication tools that handle routine patient communications so that care teams can focus on the human conversations that matter most to patients. Ethan, thanks so much for joining us. Juniper Lovato is an assistant professor of computer science at the University of Vermont and a member of the Vermont Complex Systems Center, where she leads the Computational Ethics Lab. Her research spans the ethics and governance of data, AI, and technology with a focus on fairness, accountability, transparency, and the science of stories. And I want to hear more about that. Drawing on methods from computational social science, natural language processing, network science, and complex systems, she studies how socio-technical systems composed of humans and technologies, mutually shape one another, influencing human values, institutions, and narratives. Juniper, thank you so much for being part of our discussion. I'm sorry, I don't want to feel like I have my back to you all. So, Justin, how about we start with you, because I think in some ways you can give us the 30,000-foot view. UVM Health, it's the largest healthcare provider in the state, and correct me if I'm wrong on any of these facts. You serve more than 1 million people in Vermont and northern New York. You have 5 community hospitals plus UVM Medical Center and more than 250 outpatient centers. Why don't you tell us a little bit about how widespread AI is in the system right now and where we as patients, all of us who use UVM Health, are most likely to encounter it?
Sure, yeah, so those statistics are correct.
Okay.
So we do have a fairly large footprint. I want to highlight that we also serve a very diverse patient population and over a very large rural area. So that comes into this as well. It makes us somewhat unique as an integrated health system. So AI is widely deployed, but in point solutions. So today at UVM Health, really we're focused on making sure that we select AI solutions that really help our care teams or make us more efficient. So one of our examples is ambient, which some people in the audience may have encountered. That's when a physician or a APP comes into the clinic, records the conversation after getting your consent to do that recording. And that allows them to free up kind of from the focus on the computer or writing down everything you said to focusing on you. So that's a technology that we've had and scaled over the past year and a half and has really been one of the most impactful technologies I've ever seen in my 15 years doing this. We've seen physicians who are burned out, who dread going to work, okay? Imagine your physician dreading going to work. You don't want that. With this, they've actually been able to recover from that experience. They've been able to reconnect with their patients. Some have said, I can work longer because I love my job again. And that's the best way that we can get access out to everybody who needs it in our service area. So that's our most widely deployed AI solution. We have just over 500 physicians and APPs utilizing that, on a weekly basis. We've done a couple 100,000 encounters leveraging that technology. And then there's other point solutions that are focused in areas like radiology or the emergency department or our back office functions like billing and coding. But each one has really focused on a specific workflow or use case. And to date, there's not really one that brings it all together to bridge those workflows across multiple areas. And I think as I look into the future, that's one of the big opportunities. And I don't know how long that will take, but that will definitely happen at some point.
Now, are patients always aware or informed that AI is sort of involved in their care, in the diagnostics, in screening, or is that kind of an absurd question like asking how often are computers involved?
Yeah, we've had a lot of conversation about this, really around a conversation around, I love Juniper's thoughts, honestly. So can a patient decline the use of AI in their medical care? That's the question, right? So a patient can absolutely decline the use of us recording your conversation. But because AI is kind of everywhere throughout the system, we viewed it as essentially saying, you can't use the electronic medical record to take care of your patient. That would not be something that we would be able to fulfill because it's a core part of how we operate as a system and how we keep patients safe so that we can take the best care possible for them. So whenever it has to do with recording or things that we can give patients a choice about, we absolutely will. But there are things like back-end billing and coding. There are automatic AI algorithms that run on radiology images. Those things are not really able to be stripped out because it's a standard part of the medical practice that we provide. And increasingly, it's becoming part of what I would consider the standard digital medical care for any patient.
So are humans always involved in the treatment and care decisions? When a decision is finally made that, yes, we're going to splint this, or we're going to go ahead and administer medicine, where is a human always involved?
Yes,
Okay.
is the short answer.
Okay. And so what kind of safeguards are in place to ensure that the accuracy of the AI and its fairness? And do you track mistakes or hallucinations or errors?
Yeah, so I co-chair the Health Network AI Council, which I do with a wonderful nurse named Linda Havey. We also have a patient and family advisor, a member of the community that is part of that council to provide that perspective. Every single AI solution that we evaluate or implement goes through this council. And as part of that, we have an intake process where we ask both the vendor or the company who is providing that solution a whole series of questions that have to do with how their model is trained, what kind of data sets do they use, what is their security, how do they control for bias within their own model. And then we also have a secondary questionnaire for what we call the business owner, or whoever is taking accountability for that model, and not only the model itself, but how do you implement it into clinical practice? What are the key things that you're going to measure that will demonstrate success of that particular solution? And how are you going to control for and identify anything that didn't meet that success criteria?
I see.
So that's part of the intake process, to make sure that we have really clear measures and really clear accountability by professionals to oversee these systems. And not all of them have worked. Like, we have pulled a couple back. Once we implemented them, they did not meet our criteria. We said, okay, we need to stop this. We pulled it back. We work on it with the company. Maybe it improves. Then we do it again. Maybe it doesn't, and we say, not now.
Okay. I'd like to bring Ethan into this now, because I think in some ways what Ethan's company does, OhMD, maybe sort of the first pass at, for all of us in how we interact with AI. Ethan, can you first explain what it is that OhMD, and I want to make it clear, OhMD is both the name of the company and the name of the product. But if you could explain what it is you do and the kind of problems that you're trying to solve, or you are solving.
Sure. So, is this on?
Doesn't sound like it.
Oh, no.
There we go. You got
Better?
Nope.
No? Hello? Oh, thanks, Justin. I'll scooch in here. Yeah, so OhMD, we started building this company 10 years ago to solve a problem that we all have as patients, which is you get sick, you call your doctor's office, you wait on hold, you leave a voicemail, maybe you get a call back, maybe you don't. And as it turns out, the sicker you feel, the harder this process is. And I've been through it myself. We all have family members who have been through it. And this is an administrative challenge more than it is anything else. So essentially what we do and what we've always done is use technology to streamline the process of booking appointments, getting a refill on your medication, the things that are super painful as patients for us to do that feel like they should be simple. And they're held up in a bottleneck of bandwidth and process in the front office of a practice. And so we can talk about how we do that. There's a variety of ways, but we know the pain. I think we all know what that pain is. On the practice side, Justin mentioned burnout amongst clinicians. That same burnout exists in the front office, in the back office. Imagine, and some of you maybe don't have to imagine, what it's like to step into work at 9 in the morning and put your bag down, and the phone will not stop ringing all day long. And that is all you do, is pick up the phone and say, hey, yeah, let me book you an appointment. And then before you're done that conversation, there's another one stacking up for you. And so the metric that I like to point at there is somewhere between 30 and 40% of front office staff churn out of their job every year. That's insane. And so you have this combination of things that are happening here: consumer expectations for simplicity, streamlining booking appointments and getting your refills. You have a staffing crisis on the healthcare administrative side of things. And then you have AI playing this role in this triple wave of converging things happening at this moment. And so what OhMD does is we streamline those kind of administrative functions, and we use AI to do some of them. In many cases, we use texting to simplify a conversation and make it asynchronous. So that's the high level.
Okay. Now, and you're in more than 1,200 offices nationwide, right?
Yeah. So we have 1,200 physician practices. Many of them are on the under 20 doc side of things. Some larger ones are multi-hundred doc groups, and yeah, the problem is pervasive across all specialties, and so there isn't a particular specialty we focus on. It's just the telephone is the problem, and the portal doesn't help us scale these conversations, and so that's why we're kind of everywhere.
Now, what do you hear from the providers themselves that have been with you? And equally important, what do you hear from the patients?
I'll tell you a quick story. In 2014, our biggest first pilot customer was a place called Memorial Sloan Kettering Cancer Center in New York City. And you might have heard of them. And so I remember going in, we were in startup mode, and it was me and my brother, co-founder. We moved to New York City to launch this company because at the time you had to be in the city to raise venture capital. And I remember walking into Sloan Kettering, into this general surgery group that they had. And one of the doctors was really not liking the idea of leveraging texting at the time to have conversations with patients. What she didn't like about it is that she felt that it was impersonal. And I think that was a moment for me where I'm like, okay, well, I get that, but I think what you don't understand is as a patient, what's impersonal is when I can't have a conversation with my care at all. If I can have a conversation that's asynchronous, great. That's ideal. But if my next best option is a text message conversation about coordinating my next chemotherapy, I want to have that because it's better that than nothing. And so on the provider or physician side of things, what has changed since then is they recognize that patients aren't getting the experience that they need, and staffing continuing to add people to the phones is not going to solve this problem. And so providers value this far more today than they did 10 years ago and understand the problem. And then on the patient side, again, because we're all patients and we know what it feels like to go through this experience of healthcare, we want access. We want to be able to book an appointment and get our medication refilled and talk to our doctor if things aren't going right, or our care team. And so as patients, we love it because it allows us that access that we otherwise wouldn't get.
Cool. Juniper, I want to bring you into this conversation because in some ways, and nothing against my other two panelists here, but I think in some ways you're really at the heart of today's conversation, exploring sort of the ethical issues inherent in this emergent technology. First, maybe you could start by explaining what it is you do, especially as it relates to AI, how it's trained, and the potential issues that come up.
Definitely. So a lot of my work focuses on how we and our society and our biases impact technology, impact AI. The data that goes into these models is a mirror of ourselves. So whatever we're training and feeding into these models is a reflection of our biases, and it'll learn those things. And then in turn, kind of how that technology is then impacting society, how are layoffs happening in certain kinds of areas? How are learning outcomes changing in schools that are using AI? So really trying to think about how we impact technology and how technology impacts us. I have a lot of concerns about technology, but I also love technology. This is why I'm in it. So I'm kind of a weird ethicist where I love to tinker with AI. A lot of my research uses AI in it. So I like to sort of mess around with it, but I also like to think about it very critically. I think that's really important for us to be able to continue to use these tools, right? If we mess up and we ruin trust around AI at the very beginning, that's going to ruin it for everybody long term. So I really want to think about how do we build governance and structure where we can use these tools for the betterment of our hospitals and our patients. The part of healthcare and AI that actually concerns me the most, and this won't be a surprise to the people who know me and know my work, is around consent. So I've been thinking about this a lot. Patients have been advocating around sort of increasing agency in the medical space for decades. We're fighting sort of to get rid of this sort of more paternalistic medical system for a long time, coming up with the Patient Bill of Rights, coming up with principles of informed consent. And this was a big milestone in sort of patients being able to be a part of the decision-making process of their care, to being able to have agency in sort of the discussion about what's going to happen to their bodies. And I think one of the things that I'm the most concerned about is when we sort of add AI sort of into this system, are we kind of reintroducing a new kind of paternalism? This kind of AI who is behind the scenes making decisions, making recommendations, summarizing our our stories about ourselves that we're telling to doctors, helping doctors to make decisions, is that taking away agency from the patient? And we've set up this medical system with really clear principles and tenets, right? We care about having autonomy, about beneficence, about not causing no harm, to have justice for these patients. And as we start to sort of like change the system that we're working with, that really shifts where autonomy is coming from, are we really taking enough time to think about how we have shifted those tenets that we seem to really care about? Are we really spending time to think about like how are we changing our relationship with sort of the core principles of medicine? And I don't think we have. I think we've kind of been moving really fast without thinking about some of those really core issues around consent and around autonomy, both for the doctor and for the patient. I think the doctors have a right to sort of really be concerned about their autonomy also being at risk.
How much of that has to do with the people who are developing this AI? I mean, I think we could, we've probably all heard about this algorithmic bias and Elon Musk's recent experience with the chatbot Grok, which started spewing anti-Semitic comments. But I think that, sometimes it's a little bit more subtle than that. And I'm wondering if you might be able to address sort of what does it look like? What does the workforce look like who are developing this AI?
Yeah, so I think that there's, a lot of the AI tools that we're building, they're being built in companies, right? So, and they're building them for clients. And they're going to be building these algorithms, building these AI to be optimized for their client. And that you have to optimize for something, right? So you have some kind of task that you're trying to do. Those sort of tasks are driven by profits of a company who's trying to make money for the hospital, the person that they're trying to sell this product to. That doesn't necessarily mean that they're optimizing for the sort of quality of the patient care or for all of these tenets that I was just talking about, for consent, for autonomy. Consent is actually kind of a nuisance for a lot of these kinds of things, and for security, which is also a nuisance for using AI.
How so?
So, for example, like when we start integrating AI into some of our systems, like sending SMS messages between patients and sort of a company and then to a hospital, the ability to sort of like send that message to the AI system to be able to read it and to be able to interpret it to then send that to the hospital or back to the patient, that requires an intermediary. We're sort of getting rid of a layer of kind of doctor-patient confidentiality. We're kind of getting rid of a layer of security that used to be there in exchange for this efficiency, which is really important, right? That has so many downstream sort of important tasks like burnout and for ease for the patient to sort of access this care. But there is this kind of calculus that's changing. And I don't think we're always thinking about that calculus. There's no such thing as a free lunch, right? So we're adding AI into this system to optimize for something. That means that we're going to be getting rid of something else. And we're not always thinking about what that other thing is.
Okay.
Yeah.
And Justin, I'm not going to put you too much on the spot, but I'm going to put you on the spot. I mean, I'm wondering what you think about what Juniper just said, and are those considerations that are sort of part of your regular discussions on the use of AI?
Yeah, I mean, so yes, in short, we have, is this thing on?
If you can slide it up, yes.
There we go. So we are very lucky to have an ethicist on our AI council, Tim Leahy. He has brought up many of those concerns. Mm-hmm. It is something that I do think we need to address as a society, right? Because I worry about bias. I also worry about harm, right? And so how do you balance the autonomy piece with the possibility of causing harm by not utilizing a technology? And that's tricky, right? Because if somebody is completely has agency to say, I do not want this algorithm used in my medical care. Number one, it's very technically difficult to do that. Number two, it changes the clinical care that individual would have. And number three, it could potentially cause that individual harm. And so that's where it's a very tricky place. We don't have all of the answers to this. But what we really try to do is make sure that we're asking those questions up front and that we're controlling for it as much as we possibly can. And that on net, our patients are all receiving value from this technology, or the providers are receiving value from the technology. The last thing I think is also who you partner with matters.
Yeah.
Okay? And that's part of what we assess whenever we're talking about who are we going to partner with. And so I use the ambient example a lot, but ambient's an example where we evaluated 2 different providers of that technology. Ultimately, the quality coming out of one of those providers was far superior to the other one. So ultimately, our physicians chose which one we were going to use based on their true experience of 50 primary care providers. That company that we chose, they're called a Bridge, is also physician founded. It's founded by a cardiologist out of the UPMC system. So they aligned very well. They are a for-profit company, they are venture backed, all of that type of stuff. But from a mission and culture standpoint, I very much appreciate what their founder has done, and I think that overall they very much align with the mission and culture of UVM Health.
I'm glad you brought up a Bridge, because I had the opportunity at UVM Medical Center in their emergency department to see that technology in action with one of the emergency.
Dr. Peters.
Yeah, and it was amazing. And so we sort of went through a scenario where I pretended to be a patient suffering from chest pains and pain down my arm, and I'm pale and diaphoretic, and happened in the morning, and so he's asking me all his questions like he would with any other patient, and then he sort of hits the process, and then he comes up with a summary of everything we talked about. Now that was all well and good, and Dr. Peters said to me, he said, "Well, you're a native English speaker, and this is, functioning really well." But I'm wondering, a lot of the patients who come into UVM Medical Center are not native speakers. There might be people who English is not at all part of their world. They may have a disability, which makes communication, verbal communication difficult. I'm wondering how a system like that accommodates those patients.
Yeah, so we have an obligation, and we fulfill it to make sure that we have interpreters and we have systems in place to either make sure that there is a live human interpreter, or we have essentially like a tele-interpreter service. So we can get, I don't know how many languages it is, it's dozens at any moment for someone who comes in who speaks a different language. And that's the first thing that we would do, unless a care team member fluently speaks that particular patient's language. These technologies are very interesting though, because like a Bridge can do this in multiple different languages. So it can do it in 20 plus different languages.
Wow.
And during our pilot, we had a really interesting observation from one of our pilot users who was seeing patients in an urgent care setting. And he had a patient that came in that spoke Spanish, and he brought up the iPad interpreter and had the that whole process going on. And he talked through the interpreter to the patient, and then was utilizing a Bridge to record that conversation. And then he had a Bridge summarize the note. And there was actually content in the note that wasn't fully communicated back and forth with that live human interpretation. It didn't change the outcome of the encounter, it didn't change the treatment plan, but it's kind of this interesting space where even with a human interpreter, you may not get all of that information back and forth perfectly. And frankly, with AI, you may not get all of that information back and forth across languages perfectly. But can the two supplement each other, right, so that you actually get the best information?
Now, do you, right now, that technology is completely optional for the staff, for your medical staff, correct? Do you envision that ever being mandatory?
It's hard to picture it out several years in the future.
Okay.
As the technology evolves and the functionality of it increases, so that it is more of a job aid akin to a human scribe. So it's doing multiple different things. I think that the adoption will continue to increase from our medical teams. One of the things is, how do you bring in the conversation, not just between the provider and the patient, how do you bring in other information? The conversation that happens from the nurse or the MA that is rooming the patient. That is all important information to include within that longitudinal medical record, and include it in a way that is consumable. not just for the medical professionals, but also for the patient. So one of the nice things that happen is it will actually summarize in 6th grade reading level the content of that visit for the patient. So it's like instantaneous patient instructions that summarize again for you, because I'm sure we've all been to the physician or the doctor and walked out of that room and maybe not really remembered everything that was said. I mean, I know that that's happened to me, and I'm a physician. So being able to do that at a much more detailed level, at a reading level that's appropriate for the vast majority of our patients, is again another plus that this technology helps us do that we weren't able to do before.
Great, great.
Can I do a follow-on?
Yes, you may.
Okay.
I encourage you to.
Good. No, I think this is a really important point that you brought up. I mean, the word error rate is like way worse, like 10 to 30% worse for low resource languages. So even if you have an interpreter, like you can change a lot of words and hallucinate a lot of words when the system isn't used to the language that they're speaking. But I also I think this has importance around stories, right? So these sort of these transcription models are kind of framing the discussion that's happening between the patient and the doctor. They're framing this sort of discussion, which is sort of taking moral agency away from the physician in sort of their ability to frame the story. And I think a good system would be like sort of more of a collaboration between the transcription model and the physician, where it's kind of like, is this okay? Is this what you meant? And the patient too, right? When you're talking to a doctor, you get to have these moments where you're like, that's not exactly what I meant to say. Like, let's work through this. That's not exactly how I'm feeling. Having the AI kind of be more of an iterative system so that the patient does have more agency and the doctor has more agency in that kind of a process, and they're able to like sort of frame their story sort of more accurately than maybe just getting a transcription would, sure. I guess, yeah.
Now, this is a question actually, I'd say, both for Justin and you, Ethan. Is AI being used to triage patients, to prioritize who gets to go first, who's most important right now, who's most critical?
We are using that only in kind of some radiology work lists where there is essentially triage-based pixel AI. So picture a patient who has a CT scan of their head, and there are certain conditions which you want to identify right away. Say that there is bleeding happening in that patient's head. There are systems that will assess that bleeding, and then it will flag it as a high priority, and it will put it to the top of the reading list, and so then it will go first, and the human radiologist will then read that study. That's really the only triage that we are doing at this point. There are other algorithmic-based aids that help with things like identifying patients that have sepsis, right? So sepsis, kills a lot of people every year. It is something that needs to be identified quickly and treated quickly so that patients don't have poor outcomes. So we have it's not really a generative AI algorithm, to be quite honest, but it's a system which flags for the care team, hey, this patient has characteristics of a patient that might have sepsis. And so then that cues that human care team member, the nurse, the physician, to say, okay, let me take a look at this patient. Do they have sepsis? Do I need to do something? But it increases the awareness so that then the human can act on it.
I see.
Yeah, to answer that question, through the lens of a patient picking up the phone and making a phone call or sending a text message in, what we're doing is we're using AI to classify that message or that voicemail or that conversation into about 18 categories. And then we map those categories to the appropriate care team. So rather than like treating everyone the same on the way in, you're saying, okay, well, these are the people who need a med refill, send it to the refill team. These are the people who need an appointment, or this is someone who needs to talk to the triage nurse. So there's no, I wouldn't call it triaging of those or prioritizing one over another. It's driving efficiency through the process of moving them to the right person automatically, where otherwise someone would have to like pick something and send it over to this team or that.
Right. And before we started this formal talk here, you were telling me a little bit about sort of how, you're not getting into sort of the care side of things, it was more the low-hanging fruit in the healthcare system. But I'm wondering, going forward, without giving away any proprietary secrets, of course, but what you're excited about down the road for the technology that you're using and you're developing.
Yeah, I mean, if you're focused on the clinical side of this and Justin's team and their job, like that is complicated stuff, and it's not to say that ours isn't. It's just when we're dealing with the $500 billion administrative problem, we're really dealing with a lot of overhead and streamlining of things that are non-clinical, and so there's a less criticality of addressing some of those things today, as long as we can just streamline 50% better, reduce call volume and move it, have AI book appointments. Moving forward, I believe that it's not enough to say we use AI as a software company. Every company uses AI in one way or another. Our mission isn't to automate away the patient. It's to where the patient wants those routine things to be dealt with quickly and they don't need a person, then do that so that you can free up people to have real conversations, because healthcare is unique in that it's not talking to a restaurant about getting a reservation. It's like moments of vulnerability and compassion where empathy is required and human connection is really important. So the more that we can do to leverage AI to take care of the mundane, the more we free up people to have conversations with people. And I think that's what I'm excited about just broadly is leveraging AI for that.
Okay, that's great. Juniper, I would love to be able to just, if with a stroke of the pen could give you sort of the ability to impose guardrails or traffic calming devices or whatever metaphor you want to use to sort of safeguard how AI is used in healthcare. What would you come up with? What would you suggest? Because you have some people here who could maybe listen to that.
I think for me, if I'm looking to the future towards like an agentic AI situation, the thing that I'm the most concerned about there, kind of like there's this beautiful paper. If anybody's interested in AI, you should read this. It's called The Ironies of Automation by Bainbridge. It's important reading. That talks about kind of these ironies of automation. As we start to build automation into our systems, as we start to trust them more and more, and as they become more reliable, actually seeing the errors that come out of them where they fault it becomes harder. And the irony there is that it actually becomes more important at that point as we start to automate more that the humans are able to intervene, that we actually have kind of a graceful way for the human to come back into the loop and to fix the system. But it's really hard for us to know where those errors are. And I think that's one of the reasons why I'm so interested in this kind of AI, less as us being like a supervisor over the AI and more as kind of a collaborator, because it allows this kind of iterative feedback of this sort of auditing and tracking and sort of understanding the error that's coming out, as opposed to just sort of thinking of it as sort of this, okay, well, it told me where this fracture is, then yeah, sure, let's do that. But it's like, I like it when you have the radiologist sort of involved in the process where it's like, okay, I'm looking at this, is this sort of follow what I understand about the system, or is this sort of being led through bias? And with those kinds of automation tools, like in x-rays and in fractures, that's been a huge issue for a really long time. And if you think about the history of sort of like algorithms being used to look at sort of pain in knee injuries, there was incredible amount of racial bias inside of those systems because they were trained on data from like 100 years ago from a bunch of white dudes. And pain doesn't sort of manifest the same way in other populations. So I think it's really important to have that kind of like human touch in the process. So building that explicitly into the systems instead of just sort of, oh, every year we're going to do an audit and then sort of see how we're doing and recalibrate. Having that be like a day-to-day kind of process.
I wonder if you could also say something maybe about sort of the privacy of that data, and is this data being used to train system? When I go into my doctor's office or I go into UVM Medical Center for care, is the data, even if it's sort of scrubbed of any identifying characteristics, is that used to train? Is like, how much of me is in that future AI?
Yeah, I think it depends on the systems, right? So some of the AI systems certainly sort of use training data to sort of make itself better. There's huge issues around sort of latent and sort of interaction bias there, where certain populations are more likely to seek healthcare. So the more that they sort of interact with these technology, with the AI, the more the AI is going to learn how to optimize for that specific kind of patient. That makes it so that another patient who's sort of not frequently sort of interacting with the AI is not going to be as well served as the patient that is. Some AI technology, rightfully and in really sort of more safe ways, is not using the sort of the client information to train the data. And in that case, it's also important not that there isn't any. It's not that there's no bias in there. Like, they still trained on a bunch of data that's probably pretty biased. So I think there's two different ways of looking at it for sure.
Okay.
Yeah.
Now, is our data actually used to train any of the AI systems that are in the UVM Health?
Yeah, so when we contract, we're really specific about this with every single one of our vendors, that they're not permitted to de-identify and then resell our data. We do not de-identify and resell our data. It's a really important thing because that is something that happens in the industry. It is a revenue opportunity for companies and or health systems. But at least at UVM Health, that is not what happens. What we do is we, in good partnership with those companies, provide feedback on how their models are working, what we are finding, and then they take that feedback and they may iterate on those models, but they don't de-identify and sell it outside of those contractual arrangements.
I see. And how about you, Ethan?
Same answer. Yeah. I mean, when you start working with some of these large language model companies, you pay them to say, like, all right, we're gonna use this in this way, and you're not gonna touch any of our data. The dream really is, for a lot of tech companies, is that we can pull down the models into our own environments, large language or small language models. And so it's all self-contained in our environment. Again, for us, that's pretty easy because we're booking appointments and we're scheduling appointments and we're getting refills done. So we, in many cases, have already done that. We have the models in our environment. We adjust for edge cases and hallucinations or anything that we see, but it doesn't leave our environment ever.
Okay. I want to be sure we leave enough time to hear from all of you. If any of you have any questions, you're invited to come up, including whoever left those little flyers at the back of the room. But I think this is an opportunity to ask the questions that I didn't think of asking. Maybe you don't get an opportunity. So please feel free to step up. And the only thing I will ask is please keep it brief so that we could have enough time for everyone. And more of a question than statements or theses.
Yes, you're first. You just take it and put it back.
Hi.
Hi.
Thank you all for being here. This question, I think, might be more for Juniper, but it's for everyone. When it comes to precision medicine, is AI being considered for precision medicine, especially for rare diseases, cancer, mental health, and other buckets that are difficult to respond to with the gold standard of medical care, as far as like clinical trials go? Would it supplement information from clinical trials, given the bias that we see, the racial bias that we've seen historically through clinical trials?
I think from your article, they talked a bit about using digital twins as sort of like a medical supplement for data that they don't have a lot of access to. There's a lot of debate whether or not, like, sort of using medical or digital twins, these sort of AI versions of people and data, is accurate, or if it sort of perpetuates bias. But it sometimes can help, sort of like if you want to create synthetic data. When you have an imbalance of that kind of data, that can actually be a good thing, right? Where you're making sure that, I only had 4 people of color in my clinical trial and I want to sort of amplify those people. I can create synthetic versions of them and put them into the training data. That can be very, very useful, but also there's a lot of debate about whether or not that's okay. And in mental health, this is being used, I mean, I don't know if it's quite, I would say precision medicine, but there are lots of apps like WISA and stuff that are like being implemented a lot for mental health. Using sort of whether or not they kind of get some of those nuances of sort of the human interaction. I think especially some of these like non-verbal kinds of important things like the doorknob moment or like the silences or hesitations is a big open question. So I think there is stuff that's missing from that, but you guys might have another.
Yeah, I was thinking about specifically targeted therapies.
Yeah.
Especially when there's like so much, like say in oncology, there's different types
right.
of cancers.
Yeah.
And then there's different types of genetic markers for even the same label
Right.
cancer. And then you have the rare diseases which may not have the clinical trials that are going to be specific to what someone needs now because it's so rare. So
Yeah.
I just wonder how that works with AI and how that could be ethical, given that there is a whole thing about saving patient data, whether or not it's going to be resold, and then the siloing within the medical space in general that prevents cross
Yeah.
information.
So we could have a whole panel on,
Yeah.
on just that one topic. To take it up kind of at a high level, when you start going into precision medicine, genomic medicine, literally sequencing entire genomes and sequencing, cancer genomes, it opens up this whole new world of potential treatment options. And the challenge that we all face in that space is you literally have so much data. It's like, what do you do with it? And so that's a challenge for me and my colleagues. That's a challenge for pharmaceutical manufacturers. It's absolutely a challenge in oncology. It's a very exciting time because we can treat different cancers in ways that are completely different than we treated them 1 year ago, 2 years ago, 5 years ago. Because we understand more about the actual mechanics of that individual's tumor cells and can then therefore target specific novel therapies, some of which work really, really well and have improved side effect profiles to the alternative treatments. But it is a data understanding to treatment problem where you want to make sure that you're providing tools to those care providers so that they have the most information that they can to make that best recommendation to that patient, and importantly, educate them around what all of those treatment options are. And I think that's where the autonomy piece is.
I like that.
And that's where the person, the human that you are talking to, in my opinion, will never be replaced.
Yeah.
Because I can't see somebody who's experiencing a scary healthcare situation being like, okay, thanks Grok for letting me know, right? They're gonna look for a trusted human that has knowledge that can help guide them through that.
Because especially when we think about discrimination within this healthcare space,
Yep.
there's a lot of people who may not have the language.
Yeah.
And so there's a whole thing with how communication is 70% body language.
Yeah.
So thank you both for your time.
Thank you
Thank
for the
you.
question. I want to be
Yeah.
sure we can maybe get to some more of the questions. Thank you.
Thank you. I used AI to improve my question for succinctness. Full disclosure.
Go for it.
Nice disclosure.
This question is for everyone, but Juniper, I wanted to bring the conversation back to a quote you just
Yeah.
said. You talked about the importance of having a graceful way for humans to come back into the loop. As AI becomes more embedded in clinical workflows, the system itself becomes more complex and more dependent on cloud infrastructure. How do we make sure that care stays resilient when the infrastructure fails? What does human in the loop look like during downtime, cyber attacks, or power loss when the tech can't be relied on?
I bet that's a question for you because you guys use AWS.
Yeah, so many things. First, without ripping off my microphone, I have to show you my shirt. Human in the Loop is the shirt that I have. I've been like, oh man, why did I get so cold before? So anyway, yeah, on the cloud infrastructure piece, for those of you who use anything on the internet, you know that AWS crashed for essentially a full day this week, on Monday. And we don't have great answers for that, right? as the consolidation of technology in the cloud continues to happen and AWS continues to take market share, we are increasingly dependent on them providing resiliency. And it isn't just them, right? Like you have all of these other vendors who are plugged into AWS who you know, they talk about their multi-region or multi-cloud resilient plans. And then when AWS breaks, and by the way, look up, I'm going to forget his name. There is a top engineer at AWS who lives on a boat in Hawaii. And they just try to reach this guy who has like the code to fix all the things. It's a real thing. And so, yeah, I think that's a problem. Like we have to continue to push AWS to help us solve this problem because there is no way to deliver the services that we do in our own server closets. And so we're stuck leveraging the cloud to do all of these things. And so what does it look like when it goes down? Luckily for us, we're replacing the telephone system. And so the telephone system is the human in the loop. You fall back to the telephone system and people can now make calls again. So we don't, our system, it's fine. It's okay, we survive it, and Tuesday we're back, or Monday night at 7 p.m. we're back up.
But I think it's a really good question, right? So we're adding complexity into the system, and that broadens our like vulnerability ecosystem. So there are more targets now to like intercept into the system. It was not just the patient and the doctor, or the phone and the patient and the doctor. It's now like the phone and the patient and the doctor and AWS and the SMS system and these like encryption links and all this kind of stuff where you kind of are adding new vulnerabilities that people can target. Yeah.
So.
We do a lot of preparation for things like natural disasters, pandemics, power loss. We also prepare for loss of our IT systems. It's even worse when not only do you lose your IT systems, you lose your phone systems.
Yeah.
So it is a really, really challenging problem. Our healthcare systems have an obligation, in my view, to plan for those events. Healthcare will not look exactly the same without all of these electronic systems in place, but we can plan so that we can still provide the best we can in that degraded state, right? And for many in this room, you may remember, like we experienced this in you know, at UVM Health almost 5 years ago, like today. And it was terrible. And no health system is immune from it. We've seen, you know, dozens since our own experience. But the key there is proactive planning so that then you can carry forward the most important pieces of your healthcare mission, but it will not look the same.
Thank you.
Thank you for that question. Hi.
Hi, I'm going to shoot like quick questions, more specific, okay? Is that
Go
right?
for it.
So thanks. First, how, you know, when you were determining which of the translator to use,
Sure.
and you picked
Yep.
the one because the doctor's input, how often then is that audited? More than once a year, I hope.
Tell me what you mean
briefly.
about audited.
Audited? Well, you know, when we think about us using it at home, and my son, he's 18, he's like,
Sure.
man, I hate chat. It just always is wrong.
Yeah.
That's because he's not knowing how to, you know, use it right. But you obviously are looking for errors. And so how often is it audited for errors?
Yeah, so it is audited in the same way that all of our other clinical notes are audited.
Okay,
We don't
sure.
differentiate whether or not that note was the first draft, and I want to be really clear about
Sure.
this. Every note, there's a draft, and then your physician reviews that draft and they edit for that story.
Okay. Human eyes on it then.
So human eyes
That's
are
cool.
always on these things.
Great.
And we have systems, and we don't audit every single note that our providers write, but we have
No.
systems in the
but
background.
But the physician has audited.
Correct.
So check.
Yes.
I'm
Yep.
There
good
is
for me.
each of these transcription apps does have like a thing called the measured word error rate. So
Yep.
it's looking at how many substitutions for words that didn't exist, how many insertions for words, how many deletions of words exist, and there's an algorithm. There's an equation that's used to sort of assess these different transcription tools. So I'm sure that you use that when you're trying to choose which ones to use. And they get, you know, they're trying to get better at these kinds of things, but but there's ways to audit them. Yeah.
Sure.
Yeah.
Thank you. And then I love the aspect about how that human then is more with us, because I get that through my health journey. I would record everything so that I could just be there. But in that case, my skepticism, and I'm sorry, and you don't look over this, so it's probably non-issue, but you probably worry that, okay, now they're going to evaluate that they could do these appointments in a shorter time. Is that true?
That wasn't the reason we did it.
I know it wasn't. I know. No.
That,
So,
I will acknowledge that is a skepticism of my colleagues,
okay.
right?
Fair enough.
That is an administrative
Yeah, of course.
accountability, I would call it, not my decision.
I understand.
But what I will say about our health network is that once we saw the burnout rate reduction, this is a wellness initiative. Now, we have seen some improvement in number of patients seeing access, but not because we said you have to see 2 more patients a week.
Because they're able to work longer, because they're happier. and
They're able to
content.
say yes.
Yeah.
They
Yeah.
want to say yes.
That's a good reason and stuff. Thank you.
Yeah.
For your area, you know how we have the
I'm
portals.
wondering if I'm sorry.
Oh, sorry.
I just want to be sure, maybe we could get maybe another question or two. Thank you so much. That was a great question.
Hi, on a related topic, I'm worried about error correction and verification. Not necessarily, let's just talk about English speakers who are on Medicare. As you age, you have more interactions with multiple specialists. They're in different offices. People's memories fade. And I'm worried that what goes into the record, the human is the problem, not AI, okay? The human presenting 1 week says they had this medical history, these prescriptions, they had these procedures, they get out of the office, but you get a transcript, but who reads that? It's online, they might not remember how to sign on. I have 5 different patient portals,
Yeah.
and my question is, this is a perfect thing for AI to do. I mean, I go in, I change medications each time. There should be a score that say, hey, he said he had a right ulnar nerve surgery, and it's the left that was in the last time. Okay,
Yeah.
That's my question. Is Ambien, and I go to doctors that use Ambien, and mistakes get made. That's a softball for somebody to take.
The only thing I can say to that is I think you're right. I mean, there's a stat we've been using forever in healthcare that like 500,000 people die every year due to medication errors. And that's been something I've been talking about for 20 years, way back before even doctors were using computers. So there's a tremendous amount of opportunity to leverage AI to do exactly what you're talking about. It's a no-brainer, and the value there
Zero.
for
It's a
patient
no-brainer.
care is tremendous. So yeah, I mean, I don't have much more context there to add, but I just agree with you.
Okay?
Yeah.
There's some really interesting research on like memory loss and kind of like these exact types of things. So like Dave Dringaw at the University of Vermont does work sort of with transcriptions and trying to detect memory loss from exactly these types of things. So that's an interesting, something that could be integrated into a system or something.
All
but
right.
Not.
Somebody build a company around
Yeah.
it. Thank you.
There you go. Thank you for that question.
Hi. Given I don't think it's exactly in scope, I'll table concerns about insurance companies using this sort of technology for the time being. Instead, accountability was brought up. Now, the enduring shadow of Therac 25, if people aren't familiar, was a software error in radiation therapy machines that killed several people. Of course, the role, strictly speaking, for the time being, is mostly of AI, that is in mostly administrative and non-invasive procedures. But my question is, given the robust error checking you've been putting a point on, which is important, as we've gone over, when something, perhaps inevitably, goes wrong, where does liability fall?
So in our systems, the liability ultimately falls on the licensed clinician who is making those medical decisions
I see.
and the system.
So the error checking absolves providing companies from liability.
Yes. The licensed individual is ultimately accountable for those medical treatment decisions.
I see.
Thank you.
Important question. Yeah.
Thanks all for all the effort you put into this. Very quickly, AI is really a label for a lot of different things.
Yeah.
Yeah.
And people think it's a catch-all. So it's a big umbrella.
One of the challenges.
Yeah. And my question is, because we've talked about security issues, AI really represents applications, which are based on databases. And so I'm curious about how often blockchain is utilized, because the blockchain is probably the most secure. It's really not a database, which is why it's so secure. And I'm curious, because I have background in that, and in medical technology, how often you folks are looking at that in the various AI applications you're using.
I didn't expect that question.
Me neither.
I like it. It's a great question. Yeah, I'm not an expert in the space, but I know enough to tell you that there are a handful of companies that have tried to build healthcare-specific blockchain. And because that space is so tumultuous and it's this roller coaster of like one year after another, like things, it gets a lot of attention and then it doesn't. To do that at scale requires a lot of money. And I haven't seen those companies get funded the way they would need to really embed themselves in healthcare workflows. So I think that's the biggest challenge that I've seen. It's kind of a capital investment into blockchain and healthcare to plug into the Epics of the world, which is a nearly impossible task for a startup. And so, but I think that you're right in that it at some point in time has to happen. And I believe it will. I just don't know how long it'll take.
Yeah, the companies that I consult with that are blockchain based are not in the medical field, they're in other fields.
Yeah.
And probably because they're more profitable and there aren't FDA regulations and all those other things. But it is truly going to be where we're going. And the faster we get there, the more secure we will be.
Yeah, I agree with that, for sure.
Thank you for that question.
Yeah, great question.
Juniper touched on earlier kind of the additional threat vector of moving data that is previously siloed in the EHRs out to AI companies in order to do care coordination or complex clinical decision support, things like that. I was curious if you'd seen solutions for that, and also if you'd seen kind of the federal level initiatives that have been talked about earlier in the year around interoperability, whether those will be help or a harm to patient care, and whether PHI can ultimately be kind of protected in this context.
Yeah, go ahead.
Oh, I'll be one-liner. I mean, I think that right now, like the HIPAA compliance is like a floor. It's the security and privacy there is very minimum. I think there needs to be a lot more governance before we get to something that's more meaningful. But that's just my opinion. Okay.
Interoperability is a real challenge when you're talking about true in-workflow interoperability for care team members who are very used to kind of the system that they're used to. It is getting better. There are now API standards that help smaller companies make those connections once they're approved, right? Like you can't just kind of go and do it. Patients also have the ability to download their data and bring it to whatever company they want to. So there is patient autonomy there. The APIs do allow companies to connect to very specific data elements within the patient's longitudinal medical record, whether that's like their medications or notes or problems or those types of things. But each one of them we contract with to really understand how they're going to use that data and where it goes. So again, it is really on, I would say, the health system to make sure, and that's one of the core tenets of me and my team and what we do, is to make sure that that data is staying as secure as possible.
Thank you.
Yeah.
I think we're just about out of time right now. I want to thank our three panelists here, Justin, Ethan, Juniper. Thank you so much for these insights.
Thank you.
Thank you, Ken.